Good morning. Thanks for being here. This is great to see all these happy faces out here bright and early in the morning. Thank you, Liviana, and thank you, Robin, for inviting me and bringing me here. It's thrilling to be here, and every day I discover yet another person who I know who's here, so it's exciting. As you could tell from the brief biography that Liviana gave, I have had a very bizarre career trajectory, totally unpredictable. I'm always happy to talk to grad students and young professionals about this kind of thing, because it's never the kind of thing you're taught in grad school about to what to aspire, nor what the possibilities are. So we'll put that aside, but feel free to pigeonhole me later if you'd like. And as a result of that bizarre career trajectory, I have a hybrid professional identity as both a scientist and an advocate, someone who's worked, as you heard, in research environments and from academia in particular in the early years to kind of high-level policy and governmental positions and to very basic community-based advocacy organizations. So I speak from all of those perspectives and I wear those lenses simultaneously, which is why I wanted to talk today about social research in context, because even as I'm a big fan and supporter and promoter of social research on HIV, I cannot think about what we do in social research intellectually out of context, and that context includes political and social factors that are historically framed and change. So I want to introduce just a few of those contextual frames as we think about what to prioritize in social research. So thank you for your indulgence. Can you hear me okay in the back? Great. Page down. Oh, this is like the new slide template developed by the San Francisco AIDS Foundation, so you can see our happy constituents. I wanted to begin just by saying a little bit in very general terms about what social research has contributed to the response to AIDS over the last 30 years. So these are somewhat crude categories, but I think they'll help frame today's discussion. I think there's 1, 2, 3, 4, at least 5 areas in which we could characterize what we have focused on over the years. The first being social drivers or determinants or factors or forces. I know all terms are contested in the social scientists, but you know, I'm old and tired and I don't care. I'm just gonna call them what I want. So you can fill in whichever of those words you prefer, but they're basically all about the underlying factors and mechanisms at a social level that fuel the epidemic or conversely prevent epidemics from taking hold. So that's a lot of our basic social research. Historically, there's been some attention to the social impacts of HIV. I'd say less now than there were in earlier years, looking at demographic population changes as a result of HIV epidemics at the household level, basic demographic, mortality, morbidity, population migration, and so on. Some attention to governance and security, how HIV epidemics have affected the governance of societies and national security in particular. And there's been a fair bit of attention to gender dynamics. And when I use the term gender, I include gender and sexuality and sexual identity and sexual orientation and gender relationships and so on. So it's not just a proxy for women, which it often is taken to be. We've also spent some time on social interventions research, and this is an area that I think is the least well developed and a lot of the focus these days, so I'll say more about that. But looking at policy, institutional change, structural changes, structural interventions, as they're often referred to. And there's obviously a great deal of interest in, and there should be a great deal of more interest in the social and psychological aspects of what are considered new biomedical technologies for HIV prevention in particular, looking at aspects of the desirability of new products, be those microbicidal gels or oral antiretroviral therapy taken as pre-exposure prophylaxis. You're going to hear more about these during the conference. But the desirability of these for real people, their meaning of these technologies and how they're incorporated into people's everyday lives and relationships, social issues of access to the technologies, uptake, and adherence, which is a huge issue in the field. And I'll say a little bit more about that probably later as well. And then I include implementation science and operations research because they really are social science, whether it's economics or health systems research, more traditionally in the social sciences. there's a lot of lingo about this right now, too. And if essentially it's an interest in looking rigorously at effectiveness, so getting beyond efficacy of small-scale programs or interventions, but the actual population and long-term effectiveness and sustainability of these efforts, as well as how best to scale them up and to understand how they operate. So those are just general categories in which I think we've made some progress to date in social research. And what I'm going to focus on in the talk that I was asked to give today are the two areas of social drivers, determinants, factors, forces, and social interventions, or commonly called structural interventions. And to get to them, I wanted to introduce a couple of frames. So the first one that I think shapes a lot of what we are and should be thinking about as we move forward in social research is the current concern about sustainability of the response to AIDS. And I'm just very briefly going to mention two places where that shift from an emergency response to a sustainability frame is quite pronounced. One is the United States Global AIDS Program, which is known by the acronym PEPFAR, the President's Emergency Plan for AIDS Relief. You probably know all about it. Started by President Bush a number of years ago, and it's grown to be about a nearly $50 billion US program in over 31 countries around the world. And it's pretty much a bilateral program. And in current documents, what has been said very explicitly now is the program as a whole is going to focus on transitioning from an emergency response to promoting sustainable country programs. So that's one arena in which we're going to see that shift occur. The other place, and as Liviana mentioned, was in the AIDS 2031 project. How many of you are familiar with AIDS 2031? Okay, not everybody. So this is my language, effectively a very large-scale visioning exercise that was sponsored by a number of funders and spearheaded by Peter Piot, who was the former head of UN AIDS, as you probably know. And the idea was to say 50 years from the beginning of the epidemic, which is marked at 1981, the first documented cases of HIV as reported, excuse me, in the US CDC's MMWR, Morbidity and Mortality Weekly Report. So 50 years from the onset of the epidemic as we know it, where should we be in the response to AIDS? And what do we need to do now to get to that place? So it wasn't, where do we think we're going to be? It was where should we be kind of exercise, and what do we need to do to get there? And a big part of their recommendations and the sort of conclusions of a number of different working groups, not just the social drivers group of which I was part, had to do with two things. One was the focus on sustainability, again, moving from an emergency and an urgency kind of response to a much more focus on institutionalizing the systems that can allow for a sustained response. The other big thing that came out of AIDS 2031 was the need to look at a multi-level response that included and brought much more focus to the social. Not just the biological, the individual psychological, the family and community, but the social even more broadly. So that's where we're going to go next. So this combination, multi-level, multidisciplinary response to AIDS is another current frame that I think shapes how we should think about social research. And the prevention discourse is very much obsessed these days with something referred to generally as combination prevention. So where should we be going in our HIV prevention research, and in fact in practice as well, is some version of a multi-level, multimodal, or transdisciplinary response and approach to HIV prevention. And this is the official definition from UNAIDS about what combination prevention means. I'm not going to read. Do I need to read for recording purposes, or can I assume you can see the slides? Okay, thank you. Yet another version was presented by Carlos Cáceres in his plenary talk at the last International AIDS Conference in Vienna. So this is his version, very busy, I know, and I had a hard time copying it onto this slide. But the gist of it is the overlap and interplay between biomedical strategies, behavioral strategies, and social and approaches. And he lists out what some of those are as examples. So that's another version. This, again, I reproduced from a slide that I couldn't copy officially. from John O'Merman, who's the head of the U.S. Centers for Disease Control and Prevention's HIV/AIDS division. And he was, this is his version, putting together a lot of other people's creations of schemas about overlapping, intersecting approaches to HIV prevention. So the combination prevention, again, multiple disciplines and multiple approaches, which was based on this. You may have seen this graphic. It's been reproduced a lot from an article published in The Lancet in 2008 that Tom Coates and others wrote, looking at, again, some notion of highly interactive and highly active HIV prevention, which is a combination of behavioral change, biomedical strategies. They talked about social justice and human rights as sort of social here, treatment, and then with some overlaying themes and involvements of community and leadership. So highly active HIV prevention, yet another frame for it. You can see from those schemas, they're all sort of very general, but in trying to concretize what is a combination HIV prevention strategy, what might it look like? How do you actually envision a multi-dimensional, multimodal, transdisciplinary approach? Audrey Pettifor, who's worked a lot in Southern Africa and is now at the University of North Carolina in the States, presented this at the retrovirus meeting, saying, if I were asked what would be a combination prevention approach for young women in sub-Saharan Africa who are 3 to 4 times greater risk of acquiring HIV infection than young men, and this is a really tricky thing to explain, why that disparate vulnerability, what might that combination look like in real terms? So she said some kind of individual behavioral change intervention that could get at things around self-efficacy, some dynamics of gender, and condom use and skills, for example, male and female. So some individual behavioral change intervention or program, plus some pre-exposure prophylaxis strategy, whether that's a vaginal microbicide or a rectal microbicide if they engage in anal sex, or an oral pre-exposure prophylaxis pill, some version of pre-exposure prophylaxis, biomedical, plus a conditional cash transfer program. You may have heard about this. This is one strategy in attempting to increase the economic independence, particularly of young women, so that, and the pathway is that having more independence and resources might help mitigate the chances that young women have to engage in transactional sex with particularly older men who have more resources in order to have school fees or clothes or material goods that they just want because they're modern consumers. But allowing them and their families to have some cash conditioned on something like not getting pregnant or not getting HIV or not getting other STIs. And she's working on a big project in that. So that's a somewhat social level, structural kind of intervention, plus community mobilization with men around shared kind of oppressive male gender norms that affect both heterosexual and homosexual and bisexual, all men and women. So looking at the sort of ways in which norms around masculinity have some impact. And she says, add all these together, presumably they would reduce HIV risk. So that's one good operational example of what a combination approach might look like for a specific population in a specific, generally, region, excuse me. There's another version of combination prevention, which is the NIH's version. And of course, the NIH turns everything into a randomized controlled trial. So their version is let's package individual efficacious interventions that have been demonstrated so through randomized controlled trials and put the package together and eventually test it in a randomized controlled trial. First by doing some feasibility research and modeling. But there too, the idea is to say, let's look at, and they're funding 6 projects out of this particular initiative, looking at a specific geographic locale and or a specific population group.